Welcome to Outbreak Brief, a podcast that takes you inside the world's most dangerous infections. And today we're pulling from the CDC, the World Health Organization, and stat pearls to unpack a pathogen that, honestly, a lot of us just dismiss as a relic of childhood.
Yeah, we tend to think of it as defeated, right? Like it's just this thing of the past.
Exactly. But the reality is far more concerning. It's this stealthy, systemic invader. And just because a threat feels familiar to you, maybe even feels like ancient history, that doesn't mean it isn't, waiting in the shadows for its next opportunity to strike.
It really is a pathogen that has used our own modern complacency to stage a highly effective comeback. It hasn't gone anywhere. It has simply adapted to our current behaviors.
Right. And to understand how it does that, I want you to picture a scene drawn straight from the data we found in Stat Pearls. Imagine a bustling college campus in the middle of the fall semester.
A prime target environment.
Oh, absolutely. The students walking to class are young, they're healthy, and importantly, they're almost entirely fully vaccinated. They've followed all the public health rules. Yet suddenly, they are struck by an outbreak, dorms are locked down, students are rushed to the hospital in agonizing pain, and a disease we thought we beat decades ago is just sweeping through the student body.
And what makes that specific scenario so difficult to control is a truly terrifying statistic from our sources. Up to 1/3 of the people infected with this virus walk around with absolutely zero symptoms.
Wow, 1 in 3.
Exactly 1 in 3. They're entirely asymptomatic, so they're acting as silent spreaders in the community, passing the pathogen to their friends, their roommates, their teammates, without anyone even knowing it's there.
Okay, let's unpack this. How exactly does the disease we supposedly conquered bypass our modern medical defenses to do that? Today, we are taking a deep dive into the story of mumps.
To understand how mumps operates as a silent invader, we first have to look at its biological profile. So mumps is caused by a single-stranded RNA paramyxovirus. More specifically, it's what virologists call a rubella-virus. And what makes this particular virus unique from an epidemiological standpoint is its exclusivity. Humans are its only known natural host.
Only humans.
Only us. It doesn't hide in bat caves. It doesn't circulate in bird populations. It only survives in us.
That is, when you look at the physical structure of this virus, you realize it is essentially a microscopic hijacker wearing a disguise.
That's a great way to put it, yeah.
Because inside the virus, you have the nucleic acid, which is the core containing the viral RNA. It's a blueprint. But it wraps that core in a lipid bilayer. And doesn't make that bilayer itself. It actually steals it from the membrane of our own host cells as it replicates.
Right. It takes a piece of you to hide from you.
Exactly. So the virus is wearing this cloak made of human material to evade immediate detection by your immune system.
Precisely. It looks like one of our own cells right up until it attacks. And to launch that attack, it uses specific proteins on its surface, viral neuraminidase and fusion proteins.
I found that part of the research just fascinating. If the stolen lipid bilayer is the disguise, those proteins are basically biological grappling hooks. The virus uses them to forcefully bind to the outside of your healthy cells, breach the membrane, and then just dump its genetic material inside to take over the cell's machinery.
What's fascinating here is that despite this complex, aggressive infiltration machinery, the mumps virus is actually quite stable genetically. There is only a single serotype of the virus.
So it's not constantly shape-shifting like the flu.
Exactly. Now, within that single serotype, researchers have identified 12 distinct genotypes circulating globally, but functionally, the immune system is dealing with a very consistent enemy.
Wait, but if the virus is that genetically stable and humans are its only host, you would think we would have wiped it off the map by now. Historically, mumps was just a globally endemic threat, right?
Oh, absolutely. Before we had vaccines, it was an accepted, brutal part of growing up. It caused massive epidemic outbreaks roughly every 5 years in unvaccinated regions.
Just a cycle of infection.
Yeah, mostly attacking young, school-aged children. It was considered this childhood rite of passage, but it was a dangerous one that left many children with permanent hearing loss or severe neurological issues.
But then came a major turning point in modern medicine.
Right, the 1960s.
The introduction of the live attenuated mumps vaccine in 1967. And the results were an undeniable public health victory. In the United States, we saw a staggering 99% decrease in mumps cases following the vaccine's rollout.
It was a triumph, truly. But viruses, especially ones that rely entirely on humans to survive, are opportunistic. In the mid-2000s, the narrative shifted dramatically.
How so?
Well, the virus didn't evolve genetically to beat the vaccine, but it did evolve demographically. Because routine childhood vaccination protected the youngest children, mumps stopped being a disease of preschoolers.
Oh, I see.
Instead, it found a new demographic and shifted to become a disease of young adults. We started seeing major outbreaks across the US, Canada, and Europe.
But hold on, the math doesn't quite add up there. If we had a 99% drop in the 60s and 70s, why, if the vaccine works so well, are we suddenly seeing massive outbreaks tearing through college dorms today among students who actually got all their childhood shots?
That is the exact paradox epidemiologists had to solve, and it comes down to a few critical factors. First, we have the biological reality of waning immunity.
Right.
The protection you get from your childhood vaccine doesn't necessarily last your entire lifetime. For many people, those antibody levels slowly fade over the decades. Second, there's the historical issue of the vaccines themselves.
Yeah, the World Health Organization sources detailed a major misstep with certain formulations, didn't they?
Exactly. The WHO notes that in the past, some European countries relied on a specific vaccine strain called the Rubini strain. Unfortunately, clinical data showed this strain obtained a very low level of seroconversion.
Meaning it wasn't effectively teaching the immune system to fight the virus.
Right. It was essentially firing blanks. The WHO actually had to step in and recommend that the Rubini strain be removed from national immunization programs entirely.
Wow.
So when you combine fading antibody protection in young adults with historical pockets of less effective vaccines, you create these hidden windows of vulnerability in the population.
And when mumps finds one of those open windows, it climbs right in. Which brings us to how this pathogen actually gets around. It is highly contagious, and it exploits our most basic social behaviors.
It really does.
It spreads through direct contact with saliva. It spreads through respiratory droplets when an infected person coughs, sneezes, or, even just talks animatedly in a crowded room.
Yeah.
And it spreads through fomites.
And just to clarify for the listeners, fomites are inanimate objects like shared coffee cups, water bottles, or utensils that carry infectious saliva from one person to the next.
And once that saliva makes contact with your respiratory tract, you enter a prolonged period of suspense. Because the incubation period for mumps is a grueling 12 to 25 days.
Which is an incredibly long time to be carrying a virus.
Seriously. You could be exposed at a crowded party, and you wouldn't feel a single symptom for potentially 3 full weeks. It's like walking around with a lit fuse that you can't even see.
And during that long fuse, the virus is quietly replicating in your upper respiratory tract and regional lymph nodes. This delay leads directly into the danger zone of transmission.
Right, because you're contagious before you know you're sick.
Exactly. A person infected with mumps becomes actively contagious a few days before their salivary glands even begin to show the first sign of swelling. And they remain contagious for up to 5 days after that swelling starts.
So by the time someone wakes up, looks in the mirror, and realizes they are sick, they have already been shedding the virus at peak levels for days. They've been coughing in lecture halls, sharing drinks, living their normal lives, completely unaware that they're spreading a systemic infection.
Which is why we have to look closely at who faces the highest risk when this invisible spread occurs. The most vulnerable populations include the unvaccinated, of course, but it also heavily impacts the immunocompromised, such as patients with HIV or AIDS who are experiencing severe immune suppression and simply cannot fight off the initial viral replication. It's also a major risk for international travelers heading into regions where mumps remains highly endemic.
But bringing this back to our cold open, why is a fully vaccinated college student suddenly a prime target?
It's the perfect storm of proximity in biology. College environments involve high-density shared dorm housing, close contact sports, social events, and frankly, a very high likelihood of sharing drinks. It is the exact environment this virus needs to thrive, but the biology is the deciding factor.
Because of that waning immunity we mentioned earlier.
If we connect this to the bigger picture, a landmark 2006 study of a major university outbreak revealed something crucial. Researchers found that college students who had received their childhood vaccines 13 or more years prior were 9 times more susceptible to catching mumps than students who had been vaccinated more recently.
9 times. That is a massive difference.
It is. Time is the enemy here. The longer it has been since your last shot in kindergarten, the weaker your immune system's memory of the virus becomes.
So what exactly happens when your immune system forgets and the virus takes hold? The early physical reality of the infection starts off deceptively vague. Doctors call this the prodrome phase.
Right, the early warning signs.
You get a low-grade fever, you feel lethargic, your muscles ache, and you lose your appetite. You might easily brush it off as a common cold or a mild flu.
But a few days later, the hallmark of the disease emerges: parotitis.
And for you listening, parotitis is the severe, acute swelling of your parotid salivary glands. These glands are located just below and in front of your ears, right along the angle of your jawline, and the swelling is incredibly painful.
Very painful.
Your cheeks puff out dramatically, often on both sides, making the jawline completely disappear. And inside your mouth, if a doctor looks, the Stenson duct, which is the little tube that delivers saliva from the gland to your mouth, turns angry, red, and visibly inflamed. The jaw pain is so intense that simply chewing or swallowing food becomes absolute agony.
But as painful as that is, the parotid glands are just the beachhead for the virus. Mumps has a specific biological affinity for glandular epithelial tissue and the central nervous system. Once the virus hits the regional lymph nodes, it promotes viremia.
Meaning the virus breaks into the bloodstream and floods the entire body.
Exactly. It uses your bloodstream as a highway to spark severe systemic inflammation in its preferred target organs. It can breach the blood-brain barrier and attack the central nervous system, causing aseptic meningitis or even encephalitis.
Encephalitis, that's severe brain inflammation that can lead to permanent disability or even death, right?
Yes, it's incredibly dangerous. It can also attack the pancreas, causing intense abdominal pain from pancreatitis. In females, it can inflame the ovaries, causing ophiritis, or target breast tissue, causing mastitis.
And we absolutely have to talk about the impact on post-pubertal males, because this is one of the most shocking statistics in the StatPearls data. 20%, 1 in 5 infected young men develop a complication called orchitis.
Yeah, this is severe.
It's an intensely painful inflammation and swelling of the testicles, and the aftermath is devastating.
It is. The sources show that testicular atrophy, meaning the physical shrinking and loss of function of the testicle, develops in half of those affected by orchitis.
Wait, half of the young men who get that complication experience physical shrinking of the testicle?
Yes.
That is absolutely devastating for a 19-year-old college kid. And the data says up to 30% of those cases lead to subfertility. It's not just a swollen jaw. This virus can permanently alter your future.
Which makes the clinical reality of treating the disease so incredibly difficult.
Right, so what does this all mean for someone lying in a hospital bed? If you are in agony, your brain is inflamed, or you are a young man dealing with severe orchitis, what can the doctors actually do to stop the virus?
Impartially looking at the medical interventions outlined in our sources, the news is grim. There is no antiviral cure for mumps.
Not at all.
None. Treatment is entirely supportive. That means doctors can only manage your symptoms while hoping your immune system eventually wins the war. They prescribe basic analgesics for the pain, and they recommend cold or warm compresses to try and soothe the swollen jaw or the swollen testes.
But surely for something as severe as orchitis, they can use strong anti-inflammatory drugs. What about glucocorticoids or steroids to bring the swelling down and protect the tissue?
You would think so, but the clinical guidelines state very clearly that there is no proven benefit for glucocorticoid use in cases of mumps orchitis. The inflammation simply has to run its course. It is a waiting game. And in cases where the virus attacks the central nervous system and causes aseptic meningitis, the pressure inside the skull becomes so agonizing that doctors often have to perform a therapeutic lumbar puncture.
A spinal tap, just for the pressure.
Yes. They have to insert a needle into the spine just to drain away some of the cerebrospinal fluid to relieve the excruciating pressure and headache.
That is brutal.
Yeah.
The sheer physical toll of this disease makes the protective measures we do have so incredibly important. If the hospital treatments are that limited, our entire strategy hinges on the virus never taking root in the first place.
Exactly. Our primary defense is the live attenuated virus vaccine. Today, it's primarily available as the trivalent MMR, which protects against measles, mumps, and rubella, or the quadrivalent MMRV, which adds protection against varicella or chickenpox.
And the standard schedule for that relies on 2 doses, right?
Yeah.
The first given to children between 12 to 15 months of age, and the second booster given at 4 to 6 years of age.
That's the current protocol, yes.
Let's look at the numbers, because they explain exactly why outbreaks still manage to happen. 1 dose of the MMR vaccine is about 72% effective against mumps. When you get that second dose, it bumps the effectiveness up to 86%. So it is highly effective. It prevents millions of infections, but it is not 100%.
And more importantly, there are critical blind spots in our population's immunity. Because the MMR is a live attenuated vaccine, meaning it contains a weakened but still living version of the virus, it cannot safely be given to pregnant women.
That makes sense.
It also cannot be given to severely immunocompromised individuals, like patients undergoing chemotherapy for leukemia or those with untreated AIDS. They rely entirely on the rest of us maintaining high vaccination rates to create a wall of herd immunity around them.
And there's another major gap in how we use the vaccine. With some viral diseases, like measles, if you find out you've been exposed, you can rush to a clinic, get a post-exposure vaccine within 72 hours, and it might actually prevent the illness or make it significantly milder.
Yes, but with mumps, the sources are clear. Getting the MMR vaccine after you've been exposed has not been shown to be effective at preventing the illness.
That goes back to that long 12 to 25-day incubation period, doesn't it?
Exactly. By the time you realize you've been exposed, the virus is usually already established and quietly replicating in your respiratory tract. Once the hijacker is inside the building, adding an extra lock to the front door doesn't help.
Which is why immediate infection control is paramount. On an individual level, if you are infected, the protocols require strict droplet precautions. You must be completely isolated, staying home from school or work for a full 5 days after your parotid glands begin to swell. And rigorous hand hygiene is essential to prevent spreading it via those fomites we talked about.
But on a systemic public health level, dealing with a modern outbreak required a new strategy. In 2018, the CDC made a major move. They officially recommended that individuals who previously had their 2 childhood doses of MMR, but who are identified as being at increased risk during an active outbreak, should receive a 3rd dose of the vaccine.
So they use it as an emergency booster to rapidly close that window of waning immunity in young adults.
Exactly. And the data strongly backs this up. Studies showed that administering this 3rd dose during a university or community outbreak lowered the attack rate by a massive 61% to 88%. It is a highly effective tool for shutting down transmission in high-density settings.
Okay, so where does that leave us right now, both globally and locally? We know the WHO pre-qualifies highly effective vaccine strains, like the Geraldine strain, to ensure safe and reliable procurement for UN organizations worldwide. And we know that here in the U.S., the primary villain currently circulating is genotype G.
But the most deeply concerning data point regarding where we are right now comes from a recent CDC report published in November 2023. It impartially highlights a disturbing national trend. MMR vaccine coverage rates among children in U.S. kindergartens have dropped below the Healthy People 2030 target for the 3rd consecutive year.
Wow. So that invisible net of herd immunity protecting our most vulnerable is literally losing its knots.
It is. When childhood vaccination rates drop, the risk of vaccine-preventable disease outbreaks rises exponentially. We are inadvertently providing the virus with fresh, unprotected territory to exploit.
And tracking this virus as it tries to exploit that territory is incredibly difficult, which brings us to the future of managing this disease.
It remains a major clinical challenge. When a doctor suspects a patient has mumps, they traditionally draw blood to look for IgM antibodies, which are the immune system's early first responders.
Right.
But here is the catch. In people who have been previously vaccinated but still get infected because of waning immunity, those IgM antibodies might not ever show up on the test.
Because the immune system responds differently, so the standard warning signs just stay completely hidden on the blood work.
Yes. So to confirm the diagnosis, doctors are forced to rely on RT-PCR testing, which looks for the actual viral RNA. But to do that, they need a physical swab of the virus itself from the patient.
Here's where it gets really interesting. I was reading the clinical evaluation protocols in Stat Pearls, and the physical reality of getting a high-quality swab is wild. The doctor can't just lightly swab the back of your throat like they do for strep.
No, it's much more involved.
They actually have to physically massage the patient's infected, painfully swollen parotid gland for 30 seconds. They do this to literally force the virus out of the inflamed gland, through the Stenson duct, and into the mouth so it can be collected. You are deeply massaging a highly contagious, agonizingly tender gland just to prove the invisible enemy is actually there.
It sounds awful for the patient, and this raises an important question, perhaps the most important question of this entire deep dive. Biologically speaking, because humans are the only known hosts for the mumps virus, we possess the absolute capability to eradicate it from the face of the earth forever.
We could literally wipe it out.
Yes. If we vaccinate enough people globally, The virus has nowhere to hide, no animal reservoir to retreat to, and it goes extinct. But with waning immunity in adults and dropping childhood vaccination rates in our kindergartens, we're doing the exact opposite. Are we willingly inviting the systemic invader back into our communities?
It's a chilling thought, and it leaves us with this final reflection to mull over. The greatest danger of a highly effective vaccine is that it actually erases the cultural memory of the disease it prevents. When we don't see our classmates hospitalized with brain inflammation, when we forget the agonizing reality of permanent testicular damage, we start to think the threat is gone. We let our guard down. And a virus that is perfectly evolved to spend 12 to 25 days silently incubating is more than happy to wait in the dark for us to forget. Stay informed. Stay prepared. This has been Outbreak Brief.